Today we're going to discuss selective hydromechanical debridement. I'll talk more about what that means in a few minutes. But it's important to note this is a way to treat chronic wounds. But we're not only going to debride, we're also going to remove and disrupt biofilm. And depending upon what wound care specialist you talk to, up to 100% of chronic wounds have biofilm. You can't see it, but you know that it's there because of odor and exudate and associated things with the wound site. So selective hydromechanical debridement means we're only taking devitalized tissue. We utilize a wound irrigator, which is set at 15 pounds of pressure per square inch. That's the maximum pressure that's allowed by the Food and Drug Administration. And what that does is it only takes away devitalized tissue. So we're not harming any granulation tissue, so it's important to note. At the same time, as I mentioned a moment ago, we're disrupting biofilm, and it's really important that that happens because biofilm will prevent the white blood cells from overcoming the wound. And as a result, no matter what you do, negative pressure, enzymatic debridement, autolytic debridement, if you don't disrupt the biofilm, wound healing will not take place. But this pressurized pulse irrigation, also called contained wound irrigation, everything happens in a encapsulated system, which I'll share with you in a couple of minutes. So we use a wound irrigator, again, 15 pounds of pressure, normal saline, at least 3 liters of normal saline, all done in an encapsulated system. And there's 2 different types of products. There's an abdominal product or a trunk product, and there's also an extremity product that I'll share with you. So what I'd like to do is go through what a certification would be like, or a competency, and then we'll be able to discuss each one of these points as we go through it. So it's important also to note that any clinician that is utilizing pressurized pulse irrigation is certified by the manufacturer. That's a CMS guideline that any modality that it's utilized, they should be retrained or recertified every 12 months. So we would strongly urge that to happen as well. So the first thing that we would talk about is we've received the order for this treatment. And the order is very, very basic. It's just pressurized pulse irrigation. We suggest that this is done 5 days a week. The more often it's done, the better it is. So 5 days a week at a minimum. And the rationale behind that is biofilm regenerates every 6 to 20 hours. So if we're not disrupting it on a consistent basis, then it's going to continue to proliferate. So we need to make sure that we're disrupting it. So we also have to identify the patient's allergies to topical solutions or medications. By and large, as I said, we use normal saline, 3 liters of normal saline, which is also wound dependent. We'll talk more about that. We also utilize what is known as hypoacrylate adhesives, and what that means is they're hypoallergenic, but that doesn't mean there will not be a reaction to the adhesive. So if you know patients in the past have broken down with particular dressings, then we would suggest that you use a skin prep. I happen to have one here on our table. So a skin prep would be really, really important to put down for those that have broken out before. Identify the patient and explain the procedure. We're not going to tell them we're going to selectively hydromechanically debride because they wouldn't understand what that is. But if we tell them we're going to use pressure and salt water to help their wound heal, it's a really important thing to discuss with them as well as with the family. So important note there. Assess the patient's condition. It's also a team effort that we're discussing here this morning. What that means is we've got the nursing team, the therapy team, and actually dietary is really involved in this too, the nutritionist or the dietitian. So the nurses generally do weekly wound rounds. They would assess the wound. The reason that therapy is involved is they may utilize CPT codes for reimbursement purposes. However, there are many, many facilities that have nursing do this and not so concerned about utilizing CPT codes. they're more interested rather in the actual outcomes of pressurized pulse irrigation. So important to note that. The dietitian or the nutritionist is really important as well, because protein and amino acids are critical for wound healing to take place. So there's actually three, you could say 4 members of the team, and the 4th member would be the patient as well. So the assessment is done by nursing. And then this is a aseptic technique, a clean technique. So what we've done here is we've set up an absorbent clean field. But it's important to note that an irrigator, when it is taken out of its original packaging, that is sterile. Normal saline, even though it's for irrigation purposes, is also sterile. But this is a clean aseptic technique. So it's important that we set up an absorbent clean field because we're dealing with fluids. We're going to make sure, because of the aseptic technique, that every time we leave the clean field and reintroduce ourselves, that we decontaminate our hands, either wash or use an antiseptic, as well as re-glove. I'm not going to do that during this video, but it's important to note that we follow aseptic technique. So we set up the supplies on the clean absorbent field. We would also suggest that the clinician utilize protective equipment, something like a eyewear face mask, combination mask that I have in my hand, and a minimum of this, as well as gloves. Some folks also like to wear a universal precaution gown. Does not need to be impervious. So some people feel better with that, and that's certainly fine. But you don't need to wear an impervious gown. You don't need to wear respirator masks or anything like that. But it's for your own protection that you would have eyewear, face mask, and gloves. And then we would suggest that the, the wound cleansing tip is cleansed with a bleach wipe before and after each use. Now, the irrigators are single patient multi-use. They're powered by 4 alkaline batteries in the handle here. The 4 batteries will last about 12 to 15 3-liter treatments. So single patient, we're not concerned with cross-contamination, but we are concerned with infection control. And because we're generally dealing with a lot of bacteria in the wound, we would suggest a bleach wipe. Make sure it's a bleach wipe, sodium hypochlorite, because that will kill not only bacteria but viruses as well. So we will cleanse the tip of the irrigator itself before and after each use. Now the irrigators are set up where there are 2 different ways to utilize these irrigators, and once I put the bags on, you'll understand a little bit better. But you can have a variable speed, or you can have a constant speed or pressure, and I'll show you that in a couple of minutes. So we would cleanse the tip of the irrigator before each use. Okay. We also need to connect the irrigator to the saline bag. I've already done that here, but it's a very simple thing. It's called spiking a bag. It's a very simple thing to do. There are 2 ports on an irrigation bag, and that's what we've got here. This one is for adding medication via a hypodermic needle. This one here is known as the spike port. If this were a brand new bag, there would be a plug over the spike port. Could be different colors. And then there's a sheath on the spike, and it's important to note that the spike is just a sharp 45-degree plastic tip. Could be pretty sharp, so you want to make sure that you're aware of that. And all you would need to do is you would just take the sheath off of the spike, take the plug off the spike port, and just push it up into the bag. When you see bubbles in the bag, you know that it's spiked correctly. If you go to use the irrigator and there's no fluid coming out, you just need to push this up into the bag itself. So we're also going to provide privacy. Moisture barrier we've already addressed. Position the bed to allow comfort for the patient and access to the wound. That's a very simple statement for what could be a pretty complicated task. We've got 2 anatomical models here, and I can set them up any way that I want. But if we're dealing with a wound like this in the coccyx area, we've got to make sure we position that patient so they're kind of close to the edge of the bed. We want to make sure that we've got a straight shot down so the fluid will follow gravity and run down, and you'll see that in a moment. So we're going to also suggest that we set up a trash receptacle. And the reason for that is we utilize superabsorbent polymer in the bags. That turns fluid into a solid, which means that it doesn't need to be red bagged. There is no additional cost for treating it as a biohazard. If you look at either the CDC or the OSHA definition for hazardous waste, it says that it contains free-floating body parts or free-floating body fluid. And we're not really going to be doing that because we're just locking it all up. So we would suggest that we get a clean trash barrel liner, put it inside a small waste bag, and you'll see in a moment that we would put our drainage tube and collection device in that. We would take off the old dressing, and then we'll actually put the bags on the two different models, and we'll start to do the technique. So again, two different types of bags. There's an abdominal bag, or some people refer to it as a trunk bag. And whether we're talking the abdominal bag or the extremity bag, they basically share the same components. So there is a treatment bag, which is this long bag right here. This is a standard size opening. It's important to note that there is adhesive underneath this paper. If we needed to expand this, you could take bandage scissors using an aseptic technique, cleansing the bandage scissors with a bleach wipe. Then you could expand this by almost 60%. However, you want to make sure that you have at least 1 inch of adhesive around so you have a tight seal. Then there's a procedure port. This is where the irrigator is going to go. There's a drainage tube, collection device, and here is the solidifier. This is a water-soluble pack, and this will break open when moisture hits it and turn all of the liquid into a solid. So the way that this would go, there's a few ways that clinicians could put this on. One way that we see oftentimes is to do something like that. That's okay, except you might get a kinking in the drain bag here. So it's important that we remember that fluid always seeks the lowest level. So if we did something like this, you can see that the fluid's going to run straight down. So what we would suggest is that you pull up the release paper about halfway, and then we're going to position it on the wound. What we're trying to avoid in the bottom area in particular are ripples, and that's where potentially we could get leaking that would occur. In the gluteal fold, what I'm doing is just creasing the bag. So we want to make sure that we've got a tight seal down here. We don't have to worry so much up top because the fluid again is going to run downhill. So that's the abdominal or the trunk bag. And let me show you the extremity bag. This can be used on an upper or lower extremity. The trunk bag could also be used on an upper thigh or a shoulder. It's not exclusive to the coccyx area. So extremity bag, again, procedure bag here, 2 procedure ports on an extremity bag. And the rationale behind that is we're oftentimes faced with this very same situation here where there's a diabetic foot ulcer as well as a venous stasis. So that's why we automatically put 2 procedure ports in, and then there's a drainage tube, collection device, and the solidifier that I addressed earlier. The way this goes on is just fits over the extremity. Again, upper or lower extremity. It's a little difficult when you're working plastic on plastic. It's much easier when we're working with a live patient, and notice how I can lift the leg right up. Then there's release paper here with the adhesive directly underneath. We just take the release paper. We're going to stick the bag not only to the patient's skin, but also to the bag itself. And I've got a towel that we would suggest that you would utilize to put around here just in case the irrigator were to shoot up in this direction. So now we'd be ready to go. The other thing that we would suggest is that you warm the saline in a warm water basin to surface skin temperature. And that's generally between 85 and 90 degrees. I'm at 89. Right now I have the solution is at 89 degrees as well. You don't need to have an infrared thermometer, and what you can utilize is just touching the patient's skin. If it's fairly close, what we're trying to avoid is really cold fluid against really warm skin. If you had fluid at 70 degrees, put it against skin at 85 to 90, at 15 pounds of pressure, it would be painful. So we're trying to avoid that. Now remember, we would have eyewear, face mask, and gloves. There's a perforation here in the procedure port. You just take that off. Another way to do it, particularly when you have nitrile gloves, is you can snap it open like a potato chip bag. Now the irrigator, as I said, single patient multi-use. There are 4 alkaline batteries in the handle here. They can be changed after about 12 to 15 3-liter treatments. There's a simple piston pump in here. It'll eventually wear out. You can change the batteries in the irrigator up to 2 additional times from the original battery pack. That should give you between 35 and say 45 3-liter treatments. And the average number of pressurized pulse irrigation treatments to get a clean wound is generally between 22 and 24 treatments. So one irrigator, by changing the batteries a couple of times, is more than almost double the average number of treatments. Now the irrigator itself, again, as I mentioned earlier, has a couple of different ways to be utilized. When the switch is turned towards the operator, the harder you squeeze the trigger, the higher the pressure. But remember, 15 pounds of pressure is optimal for selective hydromechanical debridement. But we always want to start at a lower pressure. So I'll show you how that works. So if we put the tip into the bag itself. So we've got the switch is turned towards the operator. So the harder I squeeze that trigger, the higher the pressure. We want the patient to get used to the sound as well as the sensation. Now, when I flip the switch towards the patient and I squeeze the trigger to the hilt, that's set at a constant 15 pounds of pressure. I can take my hand right off. And we would want to do the entire wound, but we want to pay particular attention to this eschar and slough. In addition, there is some undermining here, and at the 10 o'clock position, there's a tunnel. They're at 3 centimeters here, 3.5 centimeters here. You could get at both of those with the straight tip. However, if you have tunnels that are approaching 8 centimeters, there is a tunneling tip that can be utilized. And the tunneling tip has centimeter graduations on it. These are very expensive, but that's where biofilm is really, really difficult to disrupt. So if you have anything over, say, 8 centimeters, then we would suggest that you utilize a tunneling tip. And the way this is utilized is it just fits on. You would do 1 liter of fluid with the straight tip, 1 liter of fluid with the tunneling tip, and then finish off the last liter with the straight tip. Now, this particular wound here on the coccyx area that we're working on is about 55 square centimeters. I keep on referring to 3 liters of normal saline. That would be at a minimum. Even if we had something as small as 10 or 15 square centimeters, we still want to use 3 liters of fluid. When you have something approaching 100, 120 square centimeters, then you want to consider utilizing 2 3-liter bags. If you have something approaching well over 200 square centimeters, something this large, you should consider 3 3-liter bags. These bags, the drainage tube and collection device, will absorb up to and solidify 10 liters of fluid. So we would continue this whole process until the 3 liters were gone. And if I go over to the extremity bag, you always want to start, if we've got this same situation with a venous stasis and a diabetic foot ulcer, you want to start at the top of the wound or the top of the extremity and work your way down, again because of gravity. So we would start here Again, I would start at a lower pressure, gradually increase it to make sure they can tolerate it, and then switch as quickly as we can to 15 pounds of pressure. Once we're done with the upper wound, then we would go into the diabetic foot ulcer. And you can maneuver the entire bag and the irrigator around. We stay about an inch or two away from the wound. And we want to make sure we're doing the entire peri-wound as well as the other parts of the wound itself. And we would continue that, as I said earlier, until all of the fluid has been depleted. Now you can see here the fluid in this bag has broken open the superabsorbent bag and it's turned into a solid. Again, important to note that because you don't have to red bag it. So now we would be, the technique would be completed, so we can remove the bag. And there's always going to be a little fluid in the wound itself, and that's not an issue. Here's what we suggest for dressings. Remember, we suggest that this is done 5 days a week. You can use any dressing that you'd like, and I've got some representative samples of some very popular dressings here with me. Alevin is a very popular dressing. It's a pressure relieving, it's a foam back dressing designed to be left on for 3 to 5 days. This one here is a 5.5 by 5.5, a little too small to fit on this wound. We would need to size up. That would cost about $6.50 to $7. This is a very popular dressing. This is a hydrocolloid designed to be put on the gluteal fold. The recommended length of time for this wound is 5 to 7 days. This would cost about $12. Here's what we suggest. We want to maintain a moist wound healing environment. So a simple hydrogel type dressing, either a dressing itself or the gel itself. Because we're going to be doing this at least 5 days a week, don't spend a lot of money on dressings. A hydrogel dressing or the gel itself would cost between 50 cents and $1. And then you would need a secondary dressing, either an ABD pad or possibly a transparent dressing on here, which would be a minimal amount of dollars in order to do that. So a moist wound healing environment is really what we're looking for. Don't use products that are designed to be left on for 3 to 7 days. And then what we would do is after we put the dressing on, or actually nursing would do that depending upon the scope of practice in the individual states, then you could return the patient to their regular position, and then we're good to go the next day. Now that we're finished with pressurized pulse irrigation, let's review what we've really done. I started off by saying this is selective hydromechanical debridement. Again, to review what that means is we're only taking away devitalized tissue. So you're not harming granulation tissue. There are other methods of debridement, including surgical, excisional, or Sharps debridement. And those are non-selective, which means that you're taking away vital tissue with devitalized tissue. So it's important to note that the selective hydro is only taking away bad, devitalized necrotic tissue. That's number one. Number two, we're disrupting biofilm. And biofilm is in up to 100% of chronic wounds. That's why they're chronic. And the third thing we've done, because of that pulsation, you've noticed that it isn't a straight fluid, it's a pulsating fluid that comes out of the irrigator. So that is a stimulation. It's almost a reciprocal action, like a saw going back and forth. So that not only debrides, it disrupts biofilm, increases blood flow. And everything, as I said, is happening in an encapsulated system. So to sum up what pressurized pulse irrigation or contained wound irrigation is, we provide among the best outcomes at the lowest cost with the highest patient satisfaction. And depending upon the facility, they can utilize CPT codes for reimbursement purposes. So it just depends on how the facility wants to look at their wound care team. As I mentioned earlier, we have many facilities that use their nursing staff only. We have other facilities that utilize nursing, therapy, in order to capture those reimbursements. Thanks for listening. Bye-bye.